And that cloning technique is what is special about the adaptive immune system. So the adaptive immune system is able to clone. That cloning is what takes time. That's why the adaptive immune system takes time. So, but the clone of that T cell matches exactly what the dendritic cell presented. Does that make sense? Okay. So, but in the second, this is the first exposure, and the secondary exposure, now even just cytokines can trigger that CD4 cell to help and activate. Yeah.
Is another word for cytokines?
Lymphocytes? I haven't heard that term before, but maybe people would call it that.
Yeah.
I haven't heard that
My
term.
professor called them lymphocytes, but he had cytokines, he was talking about cytokines.
It's like cytokines released by lymphocytes?
Yeah, which is a T cell. I don't know. So I was just looking at my notes and it was just like, okay, well.
I haven't heard that term before, but that doesn't mean it's not. Right, yep. Okay, so CD8 cytotoxic T cells, they degranulate perforins and granzymes. They're turned on by a dendritic cell presented on an MHC1, which is the weird thing. This is the super weird one. So MHC1 usually will say kill me. But dendritic cells have this special power to present an antigen on an MHC1 to be able to turn on a CD8. Yeah? So then cytokine, CD4, an infected somatic cell or a body cell presenting an antigen on an MHC1, it needs all these things to be able to degranulate and then to clone. Now, if it runs into any infected somatic cell with the same antigen on an MHC1, it can kill it without any of this. The clones can. Yeah? Kind of? Yeah.
Can the CD8 cells become infected? Is it possible for those cells to be infected?
That is a good question. CD8 cell infection. Probably, but I don't know.
I was just curious how they are able to say kill me if they can't use their MHC1.
Wouldn't that be HIV?
HIV is CD4.
Okay.
Yeah. That's a CD4 infection. Yeah.
So that last part you just said, you're talking about that once it clones, once it degranulates and clones, then it doesn't need those three things anymore.
Yes.
So it doesn't need the cytokine CD4 or the infected somatic cell.
Yeah.
And then it can just continually work.
Yep.
And is this one also that only targets a very specific receptor once it's cloned?
So what it is, so like this first cell, so everybody pay attention on this part because this is kind of important. So once you have like this CD4 T cell, and this CD4 T cell is going to match some sort of antigen. So this is its job, but it's gonna match some sort of antigen. And if it matches an antigen, it can go through this process. And that antigen, this PAMP-PRR combination, this antigen receptor combination, makes this individual cell be able to go through this function because they had an exact match. If they did not have an exact match, this T cell would just die. So the exact match is the point of the VDJ recombination. The VDJ recombination is the lock and key match from the we're not talking about antibodies yet, from the receptor to the pathogen matching. So that's what VDJ recombination does, is puts out trillions of combos so that eventually it'll find one pathogen. And that one pathogen will trigger it to function. Does that kind of answer your question? Okay. So same with the cytotoxic T cell. So cytotoxic T cell goes through this process. There's one thing I wanted to change here because it will degranulate. Oh no, this will degranulate and clone. It's this one. So this one, those CD4 T helper cells, once they clone, they're gonna go, I don't wanna say that. That's just too confusing. Okay, so here the clone, what this secondary infection is, are from the clones. So the cloning is what makes adaptive immunity take longer. But it's also what makes it the most powerful. Because now we have thousands of matches to that original antigen. So it takes time for that antigen receptor match. It takes time for activation. It takes time for cloning. Now that there's clones in the lymph nodes and in the bloodstream and in all the lymphatic organs, that antigen doesn't have a chance because there's one antigen and thousands of cells that will kill that antigen before we even notice that we're sick. So it's the specificity that makes the adaptive immune system potent and powerful. Does that make sense? Yeah? Okay, please, I know it's a lot of like space. I'm not really sure how much is coming across and not, so please, just the more questions, the better. Okay, so let's move on to B cells. So we're just doing a quick little review. So B cells can do their own job. Once there's a mature B cell, its role is phagocytosis. And once the effector B cell is able to go through phagocytosis and able to turn on, it also needs the help of CD4s and cytokines. Everything needs cytokines. Did I put antigen presentation last time? I'm confused of what I told you. I just don't want to make you more confused. So a B cell can do this and take in this bacteria and phagocytose it, and it can antigen present on an MHC2 because it's a professional antigen presenting cell, and it can present that antigen. But also what that's gonna do is turn this cell on. So this cell turning on, if it matches with also a CD4, so it needs CD4 help and cytokines. Now this cell is going to turn into a plasma B and clone, a memory B, that match that exact same antigen. Plasma Bs secrete antibodies or immunoglobulins by the hundreds of thousands. Memory Bs clone, store forever, that match that exact antigen. But another option for our B cells is, here's the B cell just living its life. Here's some sort of antigen presenting cell that's going to present on an MHC2. And this B cell is going to be turned on by a different cell. So now this B cell is turned on. So option one, it was phagocytosed by itself, it's able to do that. Also, it's able to be turned on by a different cell. Now it still needs CD4 and some cytokines running around telling it to turn on. Now it's going to turn into a plasma B that's going to secrete hundreds of thousands of antibodies or immunoglobulins and turn into a memory B. Okay. Did I want to say anything else about that? Okay, so now this is the first round of the first exposure. So the second exposure, actually, they do, let me just think about the second exposure. So the second exposure, so this is the first exposure. The second exposure, they are going to, what do I want to say about that? Because they still have to, but we're not talking about immature cells. I'm trying to make it as least confusing as possible. Tell me if you're confused. We're going to trigger memory bees into more plasma cells with the same antigen. Is there anything else I want to say about that? But it still does need CD4. Memory B CD4 plus antigen.
Quick question.
Yeah.
If the B cell during the phagocytosing, right,
Mhm.
particle, whatever, and it's already creating memory B cells, why would we need CD4 cells that are also gonna?
It has to have CD4. It can phagocytose and antigen present, but it won't turn into a plasma cell without the CD4.
So the CD4 is an intermediate step for the other B cells to clone?
To be able to get a plasma and a memory, you have to have the
Okay.
CD4. Yeah.
Okay.
Yeah.
And what's the action? Is it because the CD4 cell comes and then it releases the cytokines and then it triggers other B cells?
Yes, so once the CD4 is on, some CD4s, I don't want to confuse you with that either, but some you have to have CD4 be touching, and some you don't. Some CD4s can be turned on and release cytokines, and that will turn on the bee. But that's just side note. That doesn't, it's not that important. Just
Okay.
know CD4s turn on bees.
Okay.
Yeah. Dr.
Could you
Duffy.
just reiterate again how the it's turned on by a different cell? The second part, how the B cell's turned on by another cell. Yeah, so just go through that really quick.
Yes, so these are macrophages or dendritic cells. Hypothetically other bees, but not really. So here's a B cell that can phagocytose. This is they're just diverse. They're just able to do more things, kind of like a neutrophil. Neutrophils can do all kinds of things. B cells can do all kinds of things. CD4s and CD8s kind of have their one channel. B cells can phagocytose and antigen present and make other things, like now it's going to release cytokines, now it's going to clean up, now it's going to antigen present. So it can do all that, but part of this is identification of this antigen with this receptor. Now this B cell is ready for CD4. This one didn't phagocytose. This one met up with an antigen because it was presented with an antigen. Now this cell is ready for a CD4. So it can be presented with an antigen, or it can take up its own antigen.
Did it present on MHC2 on the second part?
It presents on MHC2.
On the second one too?
This
So
one,
here,
it's
how
not
is it-
antigen presenting.
What do you mean it's
This is for another job. This is alarms. It's gonna
Right.
sound the alarms. But also what this did was turn this
Are
on
you guys
and be
asking
ready
about
for a
secondary
CD4.
infection?
No, I just mean, what do you mean when you say it meets up with another antigen on the second B cell?
Yeah, this part we can kind of forget, because this is what, all it's doing is sounding the alarms. This part,
Right.
what we're doing is how B cells turn on. They can turn themselves on, or they can be turned on by a different type of antigen presenting cell.
Okay, how do they get turned on by another cell?
So, just like the antigen presentation is gonna chew up whatever it is and spit it out, present it, it's gonna meet up with a receptor, and that's gonna send a message to the B cell, now you're ready for the CD4, now you can turn into a plasma and a memory B.
Okay, so the B cell is meeting up with either a macrophage, dendritic cell, or another B cell, and it's basically being turned off by the other cell.
Yep,
Because
and then
it
this
has-
one, it phagocytosed and turned itself on.
Okay, that makes sense, thank you.
Okay, yeah.
Is there a third option where the antigen itself activates that receptor directly, or is it always through phagocytosis?
Yeah, well, so it can phagocytose, but also it can,
Like catch the antigen?
yes, and then phagocytose that.
Okay.
Yes, yeah.
What's the advantage or the difference between having memory B cells the second time around and not having them the first time? Is it just speed?
Yeah, so I wanted to talk to you about that, because this secondary, I wanted to make this really clear what's going on with this secondary. So what it is we're looking in the whole adaptive immune system, what we're looking for is the match. We're looking for that VDJ recombination match. So we have millions of B cells, and all of these B cells are not doing anything. So they're floating around. Each B cell has its own VDJ fingerprint. So each B cell has its own fingerprint. Not one B cell has two fingerprints. Each B cell has its own fingerprint because of VDJ recombination. So VDJ recombination, again, is when the chromosomes are cut and spliced so that there's some weird amino acid sequence on that receptor. So remember, we drew an antibody. Here's the long chain, here's the heavy chain, here's the light chain, here's the variable region, here's the constant region. This is called a FAB, and this is called a FC. This is the heavy chain, this is the light chain. In this variable region, there's all kinds of different amino acid sequences, trillions of options. And the reason there's trillions is because you can have leucine, 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 isoleucine, valine, valine, leucine. I mean, all of those 20 can be in any combination of any kind. Those amino acids can be in any combination on this variable region. And what we're looking for is some bacteria out there that's going to match this exact combination. And so what happens is that these two cells found the right combination. They found a pathogen. So once they found the pathogen, the CD4 turned them on. They were already turned on by the pathogen itself. The CD4 gave them the go-ahead. They got some more cytokine messages to give them the go-ahead. Now these plasmas and memory Bs and those antibodies match that exact antigen. So now it's spitting out antibodies by the hundreds of thousands. It took a while to find it. It took a while to clone. It took a while to get going. It took a while to spit out antibodies. But now these memory Bs are stored forever. So now where the rapid part comes in is, here we go in the second one. So in the second one, yes, we need CD4 help. Yes, we need the antigen match to trigger the memory B, but there's an exact lock and key match already. So all you need is a CD4 message, lock and key. It doesn't have to do any cloning. It's just gonna spit out thousands and thousands of antibodies. Does that make sense? So that's the rapid part. It didn't need to, we have more specific memory Bs, and they can already spit out the thousands of antibodies based on that lock and key match. Yeah.
Have we already talked about how the antibodies work, like what they do to help?
No.
No. Let's do that
Okay.
right now. Yeah,
Okay.
You're
yeah.
Is the antigens different for different? Like if it's spitting out antibodies,
Yeah.
is there different types of antigens that it's spitting out? Like why wouldn't it just be the same for every?
So remember, the antigens are the foreign thing, right?
Okay, sorry, yeah.
Yeah. So the antigens are the foreign molecule, bacteria, virus, whatever that is. And the antibody will have the match to match that exact antigen.
Oh, and that's not actually getting rid of it, that's just, the lock is what's saying, okay, this is in our body right now.
Yeah, so I'll show you exactly what the antibody's doing now. So the antibodies are, the earrings keep falling out. Antibodies are one of the most important parts of the immune system, if not, I mean, CD4s arguably could be the most important part of the immune system because B cells can't turn on without them. But antibodies are what are running all over our body at any given point. So, for example, you take the COVID test in your nose, and what you're doing is you're looking for antibodies. You're not looking for COVID. You're looking for, we have so many antibodies running around that match that exact strain of COVID that you can wipe your nose with it, put it on there, and it'll find your antibodies that match that exact antigen, that COVID antigen. So you found antibodies because the antibodies are everywhere. So that's actually what we look at. And when we do ELISA testing, I have to do my little thing really quick. When we do ELISA testing in the lab, we're looking for antibodies. And that's actually what we found is we found that looking for actual antibodies instead of trying to find this needle in a haystack of the virus itself, we now, if our body has antibodies against it, we know we had it.
So is there like, when it creates the memory or it creates the clone, is that when the antibodies are being made? Like how does the body know? Like is there different types of antibodies for different, I guess there is, that's what you're just saying. But how does it create the correct antibodies for that antigen?
Yeah, so once the lock and key match right here, so this found its exact match, so that once it finds that exact match, that's what will trigger the next step. And that one B cell itself will differentiate a little bit into a plasma cell. It'll turn into this antibody secreting machine, and every single one of those antibodies matches that exact antigen. Because you could have thousands of different types of B cells. All these B cells that are running around, you have locks. Thousands of different types of locks. From every B cell has its own individual lock. One comes in, matches one B cell, that B cell will throw out antibodies that match that exact lock. All the other ones will die. It has to find a lock to the key.
Okay.
Yeah? Okay, go ahead.
Did you just say all the other antibodies will die?
All the other B cells.
Oh, B cells.
Yeah.
And then, how long do antibodies stay in your system? Because what if you don't have COVID, or are they
Yeah.
only in your system when?
It's weird, yeah,
there's
they'll
an
stay
antigen
for,
present?
yeah, even antibodies will stay for a really long time. So, for example, like my daughter had a titer test of chickenpox, so a varicella zoster. So varicella zoster, she had chickenpox when she was 2, and I didn't want her to get the varicella vaccine because she already had it. She already had chickenpox. Like, I don't want to give her more than she needs. But what they're looking for is how many antibodies does she have in her bloodstream? How many antibodies are running around against varicella zoster? And she didn't have enough to meet the benchmark, so then she had to get the vaccine. So antibodies are around all the time.
So then why isn't every COVID test positive? If
So,
you've had COVID already?
yeah, that is a good question. So because it's not in your bloodstream anymore, I would say.
Well, also, doesn't
Like
it just kind of
resident?
pull back? Like it's not gonna be full, like you have to reach
It
a
does
certain
pull back.
level
It is a
before
benchmark.
it's gonna be positive on your test. You know how the line can be very faint or darker? You have to have quite a few antibodies before the line shows up red.
And you have to have a really strong test, like you couldn't do a titer test for varicella zoster at home. You have to have the machine for it to detect like low levels of antibodies, but you would have low levels of antibodies. But that is a really good question.
Thank you.
Dr. Duffy, do you have a question?
I just have a few clarifications more. So,
Yeah.
is the whole point in the adaptive immune system basically to make antibodies?
The whole point.
Like,
Well, the
what
adaptive
these
immune
cells
system,
do.
CD4s, can help CD8s as well that don't make antibodies. But the whole point of B cells is antibodies.
Okay, and so how are the cells, like pumping out antibodies? Do they just,
Plasma cells are, so plasma cell B cells have on the surface, so you have a plasma B, and on the surface it'll have antibodies everywhere, but also it secretes antibodies by the thousands. And then once it's done secreting antibodies by the thousands, those memory Bs are gonna be stored forever in the lymph nodes and everywhere else, in the spleen and in the tonsils, that match that exact antigen and that are ready to spit more plasma or spit more antibodies against that specific pathogen.
so in the memory B cells, did you say that antibodies are remembered, or what was remembered?
Memory B cells have the antibody that match that exact pathogen.
And
So
they
that's the
remember
memory
that.
part.
Okay, and then they spit out a bunch of them.
Yep,
And
to
then
match.
the last thing also, for the first infection and second infection, is the first infection just referring to the first time the antigen and the B cell meet up? Like
Yeah.
uniquely the first time?
The first time you're exposed to it.
Okay, but just one cell? Or what do you mean by first exposure?
One cell. I'm sorry, what do I mean by what?
First exposure.
First exposure is the
First-
first time you're exposed to an illness. So like the first time you're exposed to COVID, you have to go through the cloning process.
Right, okay, so it's not the first cell, it's at the first wave of infection
The
almost?
the first time these two things meet up.
Okay,
The first time this cell's ever seen it.
okay, so and then the second time,
Now you have thousands of antibodies all over the bloodstream that match it already, and you have memory B cells that match it already.
okay, thank you.
Yeah. Keep asking questions, because I think it does help. Does it help everybody to keep asking questions and kind of dig deeper? Okay, well, just let me know too, if you guys like keep asking questions. Yeah,
In that case, I had another question.
yes, please do, awesome.
Are there always B cells floating around that have like a random code for like the receptor,
Yes.
and then if an antigen happens to,
Yes,
okay, so
it's
it's,
a great question.
so there's not a mechanism that a B cell can create a new, receptor on the variable, the FAB.
So it
section.
can create, so
It's
once
like-
it's born,
Yeah.
once the B cell is born, it has this FAB identity,
And it's random,
and it's random, but it has only one.
okay, and then if an antigen connects with it, then all of a sudden it's like, okay, well, we need more of me,
Yes, and if it doesn't, it just dies.
okay.
So it creates all kinds of randoms. It's creating a bunch, and if it happens to meet up, great. If it doesn't, they
Oh,
die.
okay.
Yeah.
Do the plasma cells die off too? The plasma Bs?
Not necessarily, because they've already found their match.
So will they always secrete antibodies or they slow down?
They slow down. They do over time, and these ones will eventually die off. These are the ones that are stored forever that will eventually turn back into a plasma B
Right.
if this one finds its match later on. in
So a
life.
memory B can match up and then be like, okay, time to make some more plasmas, so they could go and attach and fight off the infection.
And they can go spit out more antibodies, but this memory B is only for that specific.
Right.
Yeah.
So long live the memory Bs.
Yes,
Okay.
yes, that is very important. The memory Bs are why we're alive. Yeah.
So is that why we make memory B instead of just all plasma B, is because the plasma Bs die off faster than memory Bs?
Yes, these are antibody secretors. These ones are, remember, I don't know if you remember from that little, memory Bs hang out in this, we have the G1, S, G2, they hang out in this little S phase, or I'm sorry, not S phase, in this G0, in that little quiescent phase,
Okay,
and they just wait, and they're just like.
so they're just more stable than plasma B
Yes.
cells,
Mhm.
okay, so
Yeah.
that's why we make them.
Yeah.
Sorry, this is obvious, I don't know.
No,
The
please.
T cells and the B cells, like why are they different things? Or,
Why do we have each one? Yeah.
it seems like it's like it's the same thing.
Yeah, well, so they each kind of have their different role in the army. So in the Army, the CD4 are like the generals that go and say like, turn on, turn on, turn on. They're the boss. So you have to have the boss, and that's a checkpoint. So if there is not a checkpoint, then we would have too many cells turning on all the time, killing things.
So these are interacting with each other.
Yeah, so CD4s are the checkpoint that help turn on the other cells. CD8 are the ones that kill virally infected cells and cancer cells. These can't kill virally infected cells and cancer cells. They can't kill cells. All they can do is spit out antibodies. And those antibodies, I'll tell you what they do. Yeah, they each kind of have their role.
Yeah.
Okay, so here's, remember what an antibody looks like. Make sure that you know how to draw that. The heavy chain, light chain, variable region, constant region. And let's go through what each of those do. So hopefully these cells will help you. If they don't help you, let me know. We can go through them together. That's a plasma cell spitting out antibodies by the hundreds of thousands, tons and thousands of antibodies that spit out that are associated with that specific antigen. Okay, so let's go through antibodies. So we have 5 types of constant regions. So we're here talking about this section right here. Here, 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 here is a constant region. So this constant region, we have 5 types. This variable region, we have trillions of types. The constant region, there's 5 different types of antibodies. And a B cell, one single B cell, can produce all 5 types. They can switch isotypes. So those are called isotypes. They can switch different isotypes between these 5. So they can, it can make an IgG, it can make an IgM, it can make an IgA. They can make different isotypes, and those different isotypes have different roles. So here we are with IgA, IgD. So Ig stands for immunoglobulin. So we have A, D, E, G, and M. Those are our 5 types. So whatever little mnemonic you need to make to remember, it would help me if you guys come up with a good mnemonic to help me with my other classes. Every time I forget to come up with one. But IgA, IgD, IgE, IgG, and IgM.
I have one.
Yay! What is it?
It's, I don't know how people will think about this, but good moms always do enough.
Oh, I love that. We do. Ah, it's helpful in so many ways. Okay. Okay, so good moms always do enough. I love that. And kind of, if it helps you remember that, like the antibody mom, the antibody is running around helping, right? So I just put one, I want you to read through these, but the only thing I'm gonna ask you is what's on the bottom. So on the bottom row, they each kind of have their own little role, but I'm gonna go over their main roles. Let's go over their main roles first, and I'm gonna come back to this. Yeah?
Should we know how to recognize them visually as well?
No. Yeah, you don't have to recognize them. They're all the same, they just assimilate in different ways. They just come together in different ways. They can like clump together and do things, yeah. Okay, so here are the main roles. So let's look over what antibodies do in general. Antibodies are able to do something called opsonize. Opsonize is a fancy word for tag. It's just a word you have to remember. Opsonize means tag. So this is tagging the pathogen, letting the other white blood cells know to phagocytose this. This is a foreign invader. Something's wrong. Yeah.
Is this still gonna be on Tuesday's quiz, this information?
Yes. So all we're doing for Tuesday's quiz is more innate immune system and adaptive. So all immune is on open. So even from the last quiz, everything is open for Tuesday. Yeah, I just want you to review innate again, pull innate back in. Okay. So opsonize means tag. Agglutinate has the word glue in it, and that means glue together. So it'll glue pathogens together so that they can't go and do infect cells or do whatever they're gonna do. So the agglutination is the next one. They activate, so remember we had two methods of the complement proteins, which I don't really care that you know the classical and alternative, but just know that they activate the complement system. So remember the complement system was in the part of the innate immune system, we had cells, proteins, and other responses. Do you guys remember that? First round of the innate immune system was skin, blood-brain barrier, then we had chemicals, microbiota barrier, and then part of the second branch of the innate immune system was cells, other proteins, and fever and inflammation. Part of the proteins, one of them was the complement proteins. Complement proteins, what they do is you have a bacteria, and this one complement protein will match, and then it assembles a whole group of complement proteins that'll poke a hole in that pathogen. Well, there's one type of complement protein that has to already have an antibody associated with that. The antibody itself was spit out by the plasma cells. The plasma cells spit this antibody. This antibody had to match this exact pathogen. Now the complements can associate and poke a hole in that bacteria. So there's one branch of the complement proteins that have to be associated with an antibody to be able to poke a hole. Okay, and then the last one is neutralize. So they can just surround and neutralize so that that bacteria can't go anywhere, it can't spit out its exotoxins, it can't eat, it can't do anything like that. So that's also neutralizing. And it can neutralize viruses like this, where it neutralizes all the spike proteins. Now the spike proteins can't attach and be endocytosed into a human cell. So this is the benefit, right? So for example, the person next to you, hopefully not, but the person next to you had COVID. Well, if your body has already seen that strain of COVID, all those spike proteins it will recognize, you already have antibodies floating around that are associated with that specific strain. So they will neutralize it before you even feel sick, because they can't endocytose, they can't cause their cytopathic effects, they're neutralized. So those are the four main roles of antibodies. And so let's go through like some of the identification of like what an IgA, IgD, IgG, and IgM. So Ig, remember, stands for immunoglobulin. IgAs are tears, mucus, saliva. These are running around in the body at any given time. And these are the main taggers. This is their main job, is opsonizing. So IgAs are really good at opsonizing. IgDs help stimulate IgMs. So these two work together. IgDs and IgMs work together. Let's just go on and I'll tell you what IgMs do later. IgEs,
Sorry, you said what two work together well?
Ds and Ms. Ds and Ms are always partners.
D's and M's. Okay,
Mhm.
so D's and M's work together. IgA helps with optimization.
Yeah, opsonization. Opsonization, yes. Opsonizing tagging, yes. IgEs, what they do is they help the innate immune cells, mostly mast cells. So they'll help trigger mast cells. They help trigger innate cells. So these are antibodies that are promoting the work of the innate immune system. So especially with mast cells, somebody with, like, for example, anaphylaxis against peanuts, for example, like Kennedy has. So what happens is she will have too many IgEs in her bloodstream because her B cells they function in a weird way. We don't know why people get anaphylaxis and why some people don't. She has too many IgEs. And because she has too many IgEs, she'll be exposed to peanuts, and those IgEs will go crazy and turn on all of her mast cells. Her mast cells are gonna degranulate histamine like crazy, and she gets edema all in her face and neck and swelling, and then her throat closes. So that's what anaphylaxis is, too many IgEs. Okay, IgGs, these are our main antibodies. IgGs are the most prominent antibodies. And IgGs, so most plasma cells will secrete IgGs by the hundreds of thousands, tons of IgGs. And what they do is they help with phagocytosis. So they're helping trigger phagocytic cells to phagocytose. So they're like alerting phagocytic cells to phagocytose. So they can also like opsonize, they can trigger phagocytic cells to phagocytose, so they're helpers. This is our main blood antibodies. That's all you have to remember. And then IgMs, they fix the complement, so they're the complement antibodies that will trigger the complement system. But also they do help with B cells. This is the main, so the reason I wanted to say main B cell receptor is because plasma cells will spit out tons of antibodies, but the ones that usually stay docked on the antibody itself and that they won't be secreted are IgMs. So IgMs usually stay. And IgMs also will trigger the complement system. So they'll trigger that complement system to arrange and poke holes.
So they're the ones that activate?
So they will activate, yes.
Which ones are doing the neutralizing?
Neutralizing, actually, IgMs are good neutralizers. Yeah, I would say IgGs. So this is the only things that you need to remember, and this, I just tried to pull out probably the most important thing. Yeah.
So can you repeat one more time the differentiation about which one is the main one between the IgMs and the IgGs?
Yeah, so IgGs are the most common, most prominent. IgMs, like in the blood, we look, so for example, for IgGs, on a COVID test, which I'm gonna go over this in lab again, but on a COVID test, this is called a serotest. And remember, there's like the control, and if it tells you if it's positive or negative, and you put your sample here, and it's gonna run along this litmus paper, and then here it'll tell you if it's positive or not, and this one always turns on. What we're actually looking for is we're looking for IgGs. So here are antibodies that will attach to an IgG. So there's so many IgGs in the blood, this will always turn on, or in the mucus, this will always turn on. This will only turn on if there are IgGs that will attach to the virus key itself. I'm getting too crazy. Well, I'll explain that in lab. But just so you know, IgGs are mostly what's running around all the time. IgMs fix complement, and they're attached to the B cell often. And Ds and Ms work together. So even though these are proteins, this is kind of where stuff gets weird, right? These are proteins, but they are extremely potent, and they can work almost on their own. Like they just, like an antibody is released and it goes and does its own thing. And so this is why we have to be really careful, but also I put a video at the end for you guys to watch on your own that we're trying to manufacture antibodies to attack things like tumors, leukemia. Now, leukemia is almost like, for children anyway, not for adults, but for children, it's like 98% curable. And the reason is because we found a way for those antibodies to attack immature cells. We can give them a red bone marrow transplant, and then we found ways for antibodies to flow through the body that will attack those immature B cells or T cells or whatever the patient has. Yeah.
Do you want us to know, on this list of the antibody roles, which types of antibodies do which kinds of things?
This one,
Yeah.
So
Like which ones do the agglutination, or do we not need to know that?
No, I would just say A's are taggers, D's help M's, E's mast, G's main one, M's complement.
Okay.
Does that help? Okay. Just give one word. Yeah.
I remember you talking about like how she has an allergy, like the antibodies are rushed to like a site. So like could too many antibodies be bad?
Too many antibodies can definitely be bad. Yeah. So if your body is overproducing antibodies, one, that can lead to autoimmunity, but two, it can lead to anaphylaxis. Three, it can lead to sepsis. Yes. So yes, the immune system is super powerful, and if we have an overactive immune system, it can always lead to autoimmune disease or sepsis or anaphylaxis. Yeah.
So would too many plasma B cells be bad?
Yeah, usually the problem doesn't usually happen in the plasma situation. The problem usually happens back here, is where these are over triggered, or there's too many cytokines, or the Tregs, like Dr. Myers was saying, the Tregs go down, and they either self identify, which would be an autoimmune, or if we have over too many cytokines in the blood, it's turning on all these cells, and then we are getting too many plasma cells. But usually there's like a problem in the effector that makes too many. Yeah. Okay, cool. So let's move on. Okay, so we talked about memory B cells. Oh, so comparing and contrasting B cells, or T cells and B cells, that helps. Your book does a good job at that. So here's the effectiveness of the immune response. I kind of changed this a little bit. But the effectiveness of the immune response is the innate response. The primary immune response is non-specific. Even though those cells act in a rapid capacity, antigen meets, they do their thing. But they're slow to rid the body of the infection. So that curve is more, it's like less steep in that curve of the innate immune system, because it takes longer. They're just not as effective. They're not as effective, they're slower to respond. Here is the second exposure to the pathogen, so rapid that you don't even know you have it. The adaptive immune response kicks in and turns on, and that's every second and beyond. Every single time from here on out for the rest of your life, that exposure, the adaptive immune system is there and you don't even know it. Okay, so that's the innate versus adaptive immune systems. So, this is a really cool video. I want you to watch it because it talks about monoclonal antibodies, which are what we're using more and more as like a pharmaceutical, as like a treatment for leukemia, lymphoma, sometimes solid tumors. Solid tumors are more difficult because there's layers to a tumor that are not all one specific cell type. But we're trying to use monoclonal antibodies for tumors. We're trying to use it for abnormal proteins in something like multiple sclerosis, or something like Huntington's disease, or something like that. So we're trying to use monoclonal antibodies more and more as a therapeutic. But this video does a really good job explaining this is a B cell, this is a T cell. So it's a good video in that way. But actually, will you guys remind me too? I'll find another really good video for you on activation, so you guys can watch it one more time and go through it. Yeah.
For defining an immunocompromisation, is it just the adaptive immune system that's compromised?
Usually it's just the adaptive. Usually it is. That's a good point. Yeah. Some people have like low mast cell numbers or low eosinophil numbers, low basophil numbers, but that's not very common.
Okay.
The most common is low B cell, T cell function. And a lot of times it will start with the T cells. That's a good point. Yeah, awesome. So here, you don't have to watch these if you don't want to. It's just, I thought they were interesting videos that talk about leukemia and lymphoma. They talk about blood cancers and what they are. They talk about organ donation. Organ donation is a huge problem because they have to take immunosuppressants their whole life that will suppress the immune system. For example, I have a girlfriend, her name is Allie. She had a little one, and she was born with hemolytic anemia, and she needed a vitamin K shot, but she was born at home. This is why my husband wouldn't let me have my daughter at home, was because of this story. I wanted to have a home birth, but he said no because of this, which I understand. But she was supposed to have a vitamin K shot. Every child that's born gets a vitamin K shot as soon as they're born, because it's really rare, but some children have hemolytic anemia when they're born. So she was bleeding and wouldn't clot, which vitamin K helps with blood clotting. She had a hemorrhage in her brain and had a stroke. So she was in the neonatal ICU for years, actually, like the first 3 years of her life. And because they don't let you breastfeed and they don't let them eat if they're have tubes and all that kind of stuff, so they give them something called TPN. It's called total perinatal nutrition. It's like, we used to call it Gatorade. It's like this orange fluid that's in a feeding tube. So you feed neonates with this TPN, and it causes liver failure. So it's the best we've come up with as scientists to feed neonates, but it can cause liver cancer, or not liver cancer, I'm sorry, liver failure. So she had liver failure from being on TPN too long. She had to get an organ transplant. So she got her father's liver, and is great now. She has issues from the stroke originally, but she is handling the liver great. Everything is wonderful, but she has to be on immunosuppressants her whole life to have that foreign organ in her body not be attacking the liver, because it's not her own liver.
So now she's immunocompromised.
So she is immunocompromised, but immunosuppressants, they've gotten them to where you can be on this fine line. They look at their immune system like regularly. I think every 6 months to every year, they'll look at her B and T cell numbers, how's she doing, and they can lower the medication, they can increase the medication, things like that, but she is just more prone to flus, colds, all the things. Yeah.
What was the medication again? It's used because the liver is foreign?
I don't know what immunosuppressant, I don't know what the medication
But
immunosuppressants are.
It's a immunosuppressant that's used to suppress the immune response of the body that would be attacking a liver that it doesn't recognize as its own.
Yes.
Is that the case with other organ transplants as
Yes,
well?
all organ transplants, unless it's a twin, and I think that they have to be on immunosuppressants.
I don't
Yeah.
think they do that with blood either.
Yeah, with blood, I think it's okay. I think blood is okay. Yeah. Awesome. Okay, great question. Sepsis, that's a great video to watch. We're gonna talk about sepsis till no end, so if you wanna watch that one. Okay, so moving on. Everybody feeling semi overwhelmed? Oh, good. Okay, so next, was that a great? Okay, so next we talked about immune, innate, we are talking about skin integument. Okay, so I don't know if I posted these videos, but if I did post these videos, great. If I didn't post those videos, I can post them for you, but this is just one more little review of how the immune system works. It's like calling in white blood cells, and there's an infection, and it's showing you how white blood cells move to the area. So any little videos that you can watch are super helpful. Yeah, I just wanted to post those, but let me know if you guys need more. Okay. So we're shutting the door on the immune system. I'm happy to go over it again and again if you need to. And if you guys have questions, if you want to do one-on-one with me, hopefully you guys are going to meet with Dr. Rosemere on Monday, and you'll have Dr. Welsh video on Sunday, right? Tuesday. Yes, Tuesday. That's my other class. Okay, my other class, I'm just terrible. I always tell them Tuesday. They're so confused all the time. Okay, so now we're talking about our diagnostic section. So you guys try to stay with me, because I know I just totally inundated you with crazy immune system talk. And I think DDX can be easy. I don't think it can be hard. I don't think it should be hard. But the reason that students have a hard time with it is because they have a hard time, I know I talked about it one other time already, it's because on the front of their note card, it says Staph aureus. on the back of their note card, it says skin, pneumonia, bacteremia, sepsis. I can't remember what it all says on the back. It's gastrointestinal. So here are here's the, what do I want to say about that? Here is the area of infection, like the tropic tissue of the Staph aureus. But a lot of times students have a hard time going this way. If it's skin, are you gonna recognize it's Staph aureus? Instead of just saying Staph aureus causes this. So it's just, so flip your note card around and start going, okay, if it's skin, what could it be? If it's this kind of rash, what can it be? You just either make a whole new set of note cards or just try and flip-flop. But that being said, it's really just like we'll talk about one disease, one infection, and what that looks like, and maybe one or two organisms that cause it. One infection and what that looks like, one or two organisms that cause it. So if you can separate from moving your note card from one way to the other, go from that way to this way, hopefully it shouldn't be that difficult. It's just one or two organisms per infection and that's it. So hopefully you guys will stay on board with me. But again, ask as many questions as you can, as many questions as you want, and I'll help you as much as possible. So the reason I put this on here, I don't want you to memorize this, or you don't even have to look at it if you don't want to, but I put it on here for two reasons. Three reasons. My first reason is when you're a clinician, rashes will be 80% of your bread and butter. Everybody gets a rash. Nobody knows what it is. My kid had 4 or 5 rashes that I was like texting to my sister who's a doctor, like, what is this? What is, oh my gosh, what's going on? And still I'll see kids, like my girlfriend, she's got 4 daughters, and her 2 youngest ones, I am always like, what is that? That looks like a viral infection. What does she have? You know, and kids just are covered in skin stuff all the time. So you'll get a ton of that as a clinician if that's what area and field you're going into. Another reason that I've put this up here is because it helps you a little bit with the vocabulary. So I don't get too crazy with the vocabulary. I try and keep the vocabulary to a minimum, but it helps you a little bit, and if you are interested in it, you can read through this vocabulary if this is what you're gonna be dealing with. But the third reason I put it on here is because of the dichotomous key. So our dichotomous key in our unknown project is a series of dichotomizing. So dichotomizing is two is like a yes or no. And the reason that, you know, I've talked through with Dr. Abraham, who teaches micro as well, we've talked through this a bunch. And the reason why we try to emphasize the dichotomous key in the unknown project, and the reason we care about it, is because you're gonna see it so much in the clinical setting. It's also called an algorithm. It's like step 1, should I treat my patient with this or this? Well, does your patient have this? Does your patient see this? No. Okay, now I'm gonna go to the next step. It's called an algorithm. And so what you're doing is you're just following along. And it makes sense when you follow it here. It's like, oh, is it a vesicular rash? Okay, it's a vesicular rash. Are they easily ruptured? Are they not easily ruptured? If they're easily ruptured, this is what it can be. Here's your options. If it's not easily ruptured, this is what it could be. Here's your options. But when you're creating the dichotomous key yourself, it will help you to understand what goes into making it and how kind of the dichotomizing works when you're giving somebody else some instructions to follow along. Yeah?
Are we gonna draw it up like this?
Your dichotomous key for the unknown, yes.
Oh.
Yeah. So your dichotomous key is gram, positive, negative. Did I do a catalase? Positive. Whatever is going, you have to make your levels. You have 4 levels, yes or no, or positive or negative, and then going through, maybe everybody, just as a little side note, pull up your notes when we talked about that. When I said, don't lose these notes, these are very important notes. This is how you're gonna dichotomize, this is how it goes, but let me know if you want me to go back over that. Okay, so let's talk about, so just one little thing. this is, there's all kinds of different diagnostic tools. And I don't care that you memorize this or know this at all. I just wanted to throw this out there, that when you're thinking about diagnosing your patient, that there's different little mnemonics that people use. And people use all kinds of different mnemonics. There's like 100 online that you can find. This is one that I thought was kind of cool, it's called Vindicate. So Vindicate is like vindication, is like blaming. And you can use it as a mnemonic. So is it vascular? Is it inflammatory or infectious? That's us. Is it neoplastic? That means cancer. Is it degenerative, like, or deficiency or drugs? Is your patient have some sort of deficiency? Is it genetic? Are they taking drugs or pharmaceuticals? Idiopathic, do we not know what it is? Are they intoxicated? Is there something introgenic? I don't know what that means. Congenital, again, they're saying, is it genetic? Is it autoimmune? Allergy? Is it something having to do with their anatomy? Is it traumatic? Is it an endocrine hormone thing? Is it an environmental thing? So it just helps your brain go check all the boxes. So I just thought it was kind of cool. I don't want you to memorize that or know anything about it. I just thought it might be a cool thing. And one side note I wanted to give you is we are in this eye, and it could be all these other things. So we're one small portion of what your patient can have. So it's just a side note. Okay. So this is a video about wounds. So I wanted you to watch that on your own. It talks about different exudates, different colors of pus and what they mean, and if it's clear, if it's mucousy, if it's colored, and so they talk about different exudates, and that will definitely help you when you're in the clinical setting, but also I think it will help you with this section as well. Okay, so the integumentary system, I'm not gonna go into anatomy and physiology, that's not the point of this class, and you guys, most of you have to take A&P anyway. But the integumentary system is complex and really amazing. And let me see if I even care about saying that. But the epidermis, dermis, and hypodermis all have specialized structures that will help prevent infection. So there's the epidermis, the dermis, and the hypodermis. In the epidermis, these are called basal cells, and there's keratinocytes. And this is the protective layer. And this has a protective layer, also has macrophages in this layer. There's already resident macrophages. They're called Langerhans cells. You don't care about that now. But this is a really strong protective layer. And once that pathogen gets through here, either with a poke or scrape or puncture or something like that, or an infection gets deeper into the tissues, here reside the blood vessels. So the blood vessels is what terrifies us. You do not want anything in the blood. So we'll move on when we get to the cardiovascular system, what happens when there's bacteria in the blood or a virus in the bloodstream, things like that. So we'll talk about more about that. But we have a lot of different mechanisms to protect from that. We have white blood cells that run around in our cardiovascular system as well to help protect and get rid of pathogens. But we have so many different things that our integumentary system does to help protect us against infection, like salt, like mucus, like all these dead cells that help protect our body against infection. We have these tight junctions between our cells that help protect bacteria or something from getting in between. That's why as people age, those tight junctions wear down over time, and we're more prone to infection just because of the skin is not so taut anymore. Nail infection, so this is kind of this whole area. The book, this part will really help you to read the book if you have not been staying up on your reading, but just skim through the DDX section. It will really help you. Okay, so there's antimicrobial peptides, there's macrophages and mast cells, there's low pH, high pH salt lysozymes. I don't care that you know any of this, I just wanted you to get a sense of the integumentary system and kind of what's going on and the protective mechanisms that our skin does to help. But yeah, macrophages, there's Langerhans cells. Okay, so here's the ones that we're gonna remember. 1, 2, 3, 4, 5, 6, 7, 8 that are part of the integument. So we're gonna start with MRSA. So MRSA is methicillin-resistant Staphylococcus aureus. We already know what causes it, Staph aureus. Methicillin resistance means it's resistant to methicillin. If you had a plate of methicillin, or you had a little tab of methicillin on your plate, then the bacteria just wouldn't even recognize it. And they should, right? It's a beta-lactam. They should recognize it, but they don't, because they have those like efflux pump or changing the target or whatever else that they can do to defend themselves against methicillin. So this is generally called MRSA, even though they can be other types of antibiotic resistant too, like vancomycin or whatever. They can be resistant against others as well, but we've kind of categorized this resistant strain as MRSA. So what MRSA could cause all kinds of things. So we're going to move through all of our body parts, and we're going to find staph and MRSA in every body part that we go along, because staph and MRSA, they're so versatile. They have all kinds of tissue trophic areas of infection that they can cause. A skin infection or an integumentary infection caused by MRSA looks like this. So this is skin specific. If your patient has this big widening, reddening area that looks angry and hot and expanded and bumpy and mean and angry underneath their skin, it's probably MRSA. It probably is, or some sort of staph. Yeah.
So with MRSA, what is the likelihood of it spreading to other parts of your body? Is it only because it got through to the dermis layer or the hypodermis layer, or is it?
Yeah, so it is spreading, and this looks local, but you're at a high risk of bacteremia. But what can happen as well is if the patient's immune system is functioning well, you can take antibiotics for it, and your doctor will prescribe antibiotics for it, but the white blood cells are working to attack it. So if your patient is immunocompromised, they're in big trouble. If your patient is not immunocompromised, it'll go away. They'll be fine. Yeah, my husband has had this several times, and he is a MRSA carrier, and I'm sure he picked it up in somewhere or something. But also, he gets it, he's a MRSA carrier, but he tends to get it when he's fighting a fire, because he's wearing his turnouts, and it's like 100 and something inside the turnouts when you're in the fire. It's already 100 and something outside generally, and then it's 100 and something inside. And then because of the sweat and the pores open so much, and then the MRSA will get in through opening of the skin. So this is what it looks like if it's not pustular. If it's pustular, this is characteristic staph. So see how it has all the little bumpies on it? It looks gross. And it kind of looks like a pimple, but it hurts like nobody's business. My nephew had one of these, and I know it's terrible, but I lanced it myself and got rid of the pus inside there myself. And I still don't think forgives me for that. It was pretty awful. It was painful, but it was spreading, and I was like, you've got to clean that out. You need actually what they would have done in the hospital is lanced it and packed it with an antibiotic cloth. So they pack a cloth in there full of antibiotics to try and get rid of the local infection of the bacteria. But I covered it with antibacterial gel. I washed it really well, cleaned it out really well, packed it with gel, antibiotic gel, covered it, and it was fine, but it hurt like nobody's business. So that's what a staph infection looks like. It has those weird bumpies. It kind of looks like a pimple, but pimply all over in a smaller area. But if it hasn't ruptured in the skin, that's what it looks like underneath the skin. Okay, so you don't have to remember all of this, but it should be sort of self-explanatory. Because we already know it's part of normal skin flora, we know that. Antibiotic resistance, we know that, we know it's a bacteria. Community acquired, I don't want you to remember community acquired or hospital associated, where those come from. I just want you to think of what that means. Like community acquired, it means they probably got it at the gym. They probably got it, touching a patient, something like that. They can get it from infected follicles, hair follicles. They can get it from shaving, minor abrasions. Hospital associated is surgical site, bed sores, pneumonia, extremities, but we'll talk more about respiratory. So I really shouldn't have brought respiratory into it, but it can lead to respiratory issues, but we'll talk more about that later. But pneumonia is extremely common hospital-associated infection, so we'll talk more about that. Okay. So localized, 75% of MRSA infections are localized, and they won't move on to something more severe, but that's probably because 75% of patients that get it are immunocompetent, is my guess, something around there. Systemic, so it can lead to a systemic infection where this is more associated with the cardiovascular system, so we'll put that off. Many types of exotoxins, which we know about. We know it's a beta hemolytic, right? We know Staph aureus is a beta hemolytic. We know it can cause type 1, type 2, type 3 exotoxins. I don't want you to memorize which types, just know we can test it with blood agar, we know that. We can test it with mannitol salt, we know that. And we can test it with the catalase. Catalase is how we tell the difference between staph and strep. We'll talk more about that when we get to strep. We'll look at the two differences. Treat it with antibiotics. They will do a Kirby-Bauer generally on the sample. They'll take a Q-tip and do a sample, and they'll run a Kirby-Bauer on it and see what kind of antibiotics they should treat that patient with. Okay, so that's MRSA. Moving on to maculopapular rashes. So maculopapular rash, what a maculopapular rash means is it's tiny, tiny bumps over a long, wide space. It's a confluent rash. It's like larger surface area. Yeah.
What does confluent mean?
Confluent is like larger fluid. I don't want to say fluid, but larger space. It's like a broad infection. It's like over a significant
Is
portion
it like
of your patient's
even?
body.
Like an even amount of bumps all over it?
Confluent means more widespread.
Okay.
But there are these little tiny bumps, and I'll tell you what the diseases are that are associated with this. This does not look anything like MRSA, right? It doesn't look anything like that. If your patient had this, you'd be like, that's not staph. It's not a staph infection. What is it? It can be measles, rubella, or roseola. So measles is a virus, rubella is a virus, and roseola is a virus. So MMR is measles, mumps, rubella. That's what a lot of people will get vaccination for. And measles, we worry about a lot. Measles is a big problem. And again, you don't have to remember this, but what you do have to remember is how to identify it. So I want you to be able to look at a picture of staph, a staph infection, and be able to say that is a staph infection. Look at a maculopapular rash and say it could be this, this, or this. And the way that you can tell the difference between measles is sometimes they'll have these things called complex spots. So that would be the first thing you'd look at in your patient. If you assumed your patient had a maculopapular rash, you'd look at their throat and say, oh, do they have complex spots or not? That might trigger my next decision-making process of whether they have measles or not. Measles is not very common at all. Measles outbreaks are tracked by the CDC. We've almost rid ourselves of measles, but measles have bouts that come up, even in vaccinated patients. They cause syncytia, so I don't want you to remember that measles causes syncytia. It's just a good time to remember what syncytia is. And it can lead to a respiratory, it's highly contagious. We look for it with an ELISA test, or a PCR, and we're give you a live attenuated vaccine. So I won't say measles. How do we look for measles? How do we, what kind of vaccination is a measles vaccination? I won't ask you anything specific on that. Know what measles looks like, maculopapular rash, know what complex spots look like, but what I want you to do is go back through those, because if I say measles is a live attenuated virus, what does live attenuated mean? Or if I say we use ELISA to detect for measles, then you know what ELISA means, but you don't know what that means yet. We haven't done that yet. Okay, so rubella is rubevirus. It gives you a little bit of information about rubella. It's way less virulent. It's called the 3-day measles. It's short, respiratory infection. It inhibits mitosis, so cell division, so that's a little bit scarier than syncytia, but actually this is way more virulent. Okay, so then roseola is actually a type of herpes virus. There's tons of viruses that are actually in the branch of herpes viruses. But roseola, 100% of the population has had roseola. All of us, all the kids, everybody, at one point gets roseola. Almost every single child, all over the world. And they will have some sort of confluent rash, and you're like, what is this? My kid has a rash. It'll go away. It was roseola.
That's not
A lot of
strep
times.
throat, is it?
I'm sorry, what?
It's not strep throat, is it?
No, it's not strep throat. And these complex spots are not strep throat either. Yeah, so roseola is not associated with complex spots, that's just measles. Roseola is just a virus that causes a rash. That's it. There can be a high fever, there can be with or without a rash. It's a latent virus, which all herpes viruses are. So that's a good idea to figure out what is a latent virus. I don't care that you remember it's a latent virus, I just want you to review what a latent virus means. Okay, I'm gonna jam through these. Impetigo, so impetigo, this is what impetigo looks like. It's honey-colored bacterial infection. This one, I wouldn't give you a picture that looks like this, because this kind of looks like ringworm a little bit. Remember, ringworm is what? What pathogen is ringworm? What broad category?
Is it a flatworm?
It's a fungus.
It's a fungus, so that's right.
Ringworm is a fungus. It's not a worm. So here, remember, it's our tinnias. That's all the tinea capitis, tinea conformis, tinea, all those. Okay, so, but impetigo usually has this honey color. A lot of times kids will have this around their mouth from sucking on a binky or putting their hands in their mouth a lot, because the skin is moist, and when the skin is moist for long periods of time, just like you know, like when you swim in a swimming pool too long, then your skin gets really soft and it will allow an infection in. So a lot of times kids will get it around the mouth. It's caused by strep pyogenes or Staph aureus. So those are our two that are common causes of impetigo. The most is strep pyogenes. Highly contagious, most common in children. A lot of homeless people actually will come in with impetigo. You'll see that honey-colored crusty skin, and that's what it is. Topical antibiotics or oral if it's over a large area of the skin that you feel like you can't control with some sort of topical. Okay, but again, I won't ask you, the only thing I'm gonna ask you is the organisms that are associated with it and what it looks like. Okay, cellulitis. So cellulitis looks like a staph infection, looks like MRSA, except it's over a larger area. There's a big, large area of tissue, and that's called cellulitis. And it's an infection that reaches to the hypodermis. And so usually this is a big, large area infection. This is called cellulitis. It's actually way more common than you think. So also something I just wanted to throw out there, that it can be something, it can cause lymphangitis. And lymphangitis, this is an infection in the lymphatic vessel. That's weird looking, right? You can see the lymphatic vessel. There's an infection in the lymphatic vessel itself. But that's just a side note. So cellulitis is something that you want to recognize. It can be strep pyogenes or Staph aureus, but it also can be caused by kind of anything except protozoa or helminths. So it can be caused by any Pathogen, the most common are Staph pyogenes, Strep pyogenes or Staph aureus. If it progresses, it can lead to bacteremia, it can lead to bacteria in the bloodstream. There's generally a good prognosis in immunocompetent patients. So this one is really gnarly. It's very, very rare, fortunately. It's called staphylococcal scalded skin syndrome, or SSSS. So staphylococcus scalded skin syndrome is from Staph aureus. It's most common in newborns and babies, but it's very rare. So it's more common in children, but it's very, very rare. 1 to 5% mortality, 50 to 60% mortality in adults. Adults generally will get treated way before a staph infection progresses to SSSS, but homeless patients, sometimes patients that don't have access to health care, things like that, can end up with this syndrome. So there's a special type of Staph aureus that will cause this. 30% of adults are asymptomatic carriers. I don't want you to know any of that. It's just something to read and kind of do all of your review. Okay, these are vesicular. How many more do we have? Pustular. Oh boy, I forgot. Okay, I think we might actually have to call it. Let me just finish with, where are we at? Pustular, cutaneous, eye. Where are we? Okay, vesicular. So these are rash with non-pus filled vesicles or serous fluid. So these are they look like pimples, but they're not. So they could be a clear fluid, or they're not poppable, like nothing's coming out. And so these are vesicular rashes. And these vesicular rashes, this does not look like a confluent rash. It doesn't look like MRSA. They are widespread. It can be widespread, but they're also where you can't pop them. They're bubbles that you can't pop. So generally, this is chickenpox. So chickenpox or the shingles. Chickenpox in children, shingles in adults, varicella zoster virus, you should know that. Anything else you don't need to know, that's all just stuff to review. Okay, pustular, or these are purulent. So these purulent rashes or pustular rashes, you can pop, that they do have pus in them. They're full of pus. Purulent, pustular, they're filled with pus. So these are little vesicles that actually will pop and fluid will come out. So something called folliculitis. This is where all of the follicles have an infection, and really you can't pop a lot of these, but you could. Like some of them, if they do have pus underneath them, you could. And they're associated with the hair follicles, and that's most common in shaving. So shaving will introduce, when it's shaven and there's an empty pore, it cuts down the hair beyond the follicle, or in women's legs or pits or things like that. Then it's generally Staph aureus. It can also be caused from hot tubs, but it's very mild. Leishmaniasis is another pustular, but it's rare and extremely virulent. It's from remember the vector from the sandflies. Wasn't it sandflies or sandfleas? Sandfleas. All right, sounds right. Okay, large pustules. They'll erupt into skin lesions, and we'll use an antiparasitic because remember this is the topical, the cutaneous protozoa that's aerobic, our one only aerobic protozoa. Okay, so then we'll go over our mycoses next time, all of our tinnias. Okay, so remember on the quiz, it won't be anything having to do with DDX. We'll finish on skin next time. It's only innate and adaptive immune systems. Cover everything from innate and adaptive, and I will